mental health literacy that we see in developing countries. So mental health literacy being an awareness of your symptoms, an awareness and having a language for what things like depression and anxiety are, is typically lower in lower income countries, which means that it's not talked about at schools, it's not talked about in the home amongst friends and family, and even healthcare practitioners, doctors and general practitioners and physicians may not have this language to be able to identify symptoms like low mood or worries as signs of a mental illness or a mental health challenge. If you're someone living with a mental illness in Sri Lanka, you are much less likely to be able to get access to the mental health care, to a specialist who can help you and manage your symptoms and treat your illness than you are if you are the exact same person living in a developed country like Australia, where many patients he sees actually come from a different city in that same country. And patients in his city where he works will actually go and see psychiatrists, travel hours away, not in their home city, because they are afraid of knowing the psychiatrist, someone seeing them going into that psychiatrist's practice, and of course, people finding out, that's spreading around and then bringing shame on their family. Before we dive into today's episode of the Mental Wellbeing College, an important disclaimer. We do dive into the weeds of mental health, which means that at times we discuss sensitive topics like suicide, self-harm, and substance abuse. If hearing such discussion does bring up distress for you, please do seek the psychological and professional treatment that you need. The content covered in this episode is not intended as a substitute for professional mental health treatment. There is a perception that mental illness is just a Western construct, and that, in fact, we don't see the same rates of mental illness in developing countries that we do in developed Western countries. Indeed, we do see that mental illness is actually under-researched in developing countries, something in psychology known as the weird phenomenon. Western, educated, industrialized, rich, and developed countries tends to be where the bulk of mental health and psychology research is. So, for example, a particular data point shows that up to 87% of mental health intervention trials, so looking at different treatments and ways in which we can reduce mental illness and mental health challenges, up to 87% of such trials occur in developed and higher income countries. However, mental illness is not just a Western problem. In fact, it's estimated that out of the approximately 1 billion people living with a mental illness, roughly 80% of those people are living in middle and low income countries. So in fact, mental illness is not just a Western problem and is unfortunately very deep rooted in developing countries, which we'll explore throughout today's discussion. There are many reasons why mental illness does propagate in developing countries, and many unique factors that predispose someone living in a developing country to potentially facing a mental health challenge. For example, exposure to war zones and conflict can leave you with trauma if you're witnessing heinous acts of violence, and indeed trauma and stressor-related disorders like post-traumatic stress disorder. And then there's the lack of mental health literacy that we see in developing countries. So mental health literacy being an awareness of your symptoms, an awareness and having a language for what things like depression and anxiety are, is typically lower in lower income countries, which means that it's not talked about at schools, it's not talked about in the home amongst friends and family, and even healthcare practitioners, doctors and general practitioners and physicians may not have this language to be able to identify symptoms like low mood or worries as signs of a mental illness or a mental health challenge. And then prolonged exposure to having a low income or to being entrenched in poverty can leave you with a lot of anxiety and stress around things like, where's my next meal going to come from? How am I going to afford basic healthcare for my family? And then a big driver of the problems with mental health care in developing countries is the treatment gap. So the treatment gap simply is the opposite of treatment coverage, and means that there is a larger percentage of people with mental illness who do not have access to mental health care living in developing countries than there are in developed countries. So if we take a case of Sri Lanka, which is a small island underneath India, it's where my heritage and my parents are from. In Sri Lanka, if we look at the mental health care there, we have a total of 61 psychologists and about 123 psychiatrists for the whole country. Now we can compare that to the mental health care in Australia, which is where I currently live, which has approximately 4,000 psychiatrists rather than the 120 in Sri Lanka, and about 30,000 psychologists compared to the 60 in Sri Lanka. And this is with similar populations between the two countries. So just by this sheer case study alone, you can see that if you're someone living with a mental illness in Sri Lanka, you are much less likely to be able to get access to the mental health care, to a specialist who can help you and manage your symptoms and treat your illness than you are if you are the exact same person living in a country, a developed country like Australia. And the knock-on effect of this is that people have less access to medication like antidepressants and antipsychotics, which are first line or leading recommended treatments for many mental illnesses like schizophrenia, for example, and less access to a therapist, someone to engage you in cognitive behavior therapy or forms of talk therapy, which can help you immensely. And ultimately, it also means that when you do see a mental health care practitioner in developing countries, you're less likely to get high quality care because that person can spend less time with you, given there is still a demand for their services, yet so little other mental health care practitioners in that same country. I was speaking to a psychiatrist in Sri Lanka recently who said that when he was working in Australia, he would see 6 to 7 clients per day, patients per day to engage, and he could engage in things like CBT, cognitive behavior therapy, various forms of talk therapy, as well as managing their medication. However, now that he's working in Sri Lanka, given again there's only 120 psychiatrists to service the whole country's population, he sees upwards of 30 to 35 patients a day. And what that means is that he can't engage in talk therapy as much. It's often very quick medication management only, which is fine for some patients, but for many needing deeper, more psychotherapy type care is going to lead to them not getting the quality of care that they perhaps otherwise could in developed countries which are resourced better from their mental health care services. So ultimately what we have is with the story so far is high mental health care needs, but low mental health care support, culminating in a big treatment gap in developing countries. And then, of course, there's the big unique risk factor, the big challenge in developing countries of stigma. And of course, this exists in all corners of the globe, but particularly in countries where there is a lower mental health literacy, there can be an even larger stigma of people with mental illnesses and mental health challenges. And often what this means is that someone suffering with a mental health challenge, with mental illness, whether it's their anxiety, their depression, a psychotic episode, will suffer in silence rather than risking social ostracization for themselves and their family as well. Because particularly in many developing countries that are more collectivist societies, where the group, the family unit is extremely important, and your own accolades, achievements, symptoms, mental illnesses reflect not just on you, but on the perception of your whole family. This can be an even bigger risk factor, given people may not want to disclose something which may lead to shame on the family unit overall. And ultimately, this person may suffer in silence. So again, a psychiatrist that I was talking to in a developing country, he was telling me that where he is, many people, many patients he sees actually come from a different city in that same country. And patients in his city where he works will actually go and see psychiatrists, travel hours away, not in their home city, because they are afraid of knowing the psychiatrist, someone seeing them going into that psychiatrist's practice, and of course, people finding out, that's spreading around and then bringing shame on their family. So there's this perception of someone with a mental illness is less of a person, as there's this moralization of mental illness, which exists in all corners of the globe, but particularly in countries with low mental health literacy, which unfortunately is a lot of developing countries. And in some of these countries, the idea is that when you marry someone, you don't just marry that particular individual, but you marry into their family. And unfortunately, the case is that if there's a known case of mental illness, particularly a serious mental illness like depression or schizophrenia, then that can mean that that person doesn't get married, or they have to, quote unquote, marry down in social status, or even their siblings have the same plight, given the stigma that comes along with having a mental illness in countries with low mental health literacy. And there's an argument to be made as well that mental illness can actually cause poverty, predispose someone to poverty, or reduce their income significantly, particularly in developing countries. So what often happens is that, particularly in these countries where mental illness is stigmatized so much, you are less likely to be offered a job, to be able to gain a promotion, given if it comes out, so to speak, publicly that you do have a mental illness. And then also we're looking at, particularly again with serious or severe mental illnesses like bipolar disorder, depression, schizophrenia, that some of these can be very, very, very debilitating on your day-to-day ability to function, in your ability to sleep, concentrate on the task at work, to be around other people, for example, if you're going through an acute psychotic episode. And in these countries where perhaps there's no insurance, there's no welfare system, or a real lack of a welfare system, it can make it very difficult financially if you're unable to keep a job, if you're not offered a job, and you can find yourself very quickly slipping down the economic ladder because of the presence of a mental illness. And then living in poorer areas and indeed in poverty can also drive up distress. Mental health concerns can trigger mental health episodes of depression, for example. If, for example, you're exposed to interpersonal violence, domestic violence, high substance use in the home and in people around you, these can all be triggers for your own mental illness or your own psychological distress increase. And these do propagate, and you have a higher rate of exposure to these things in poverty and poorer areas. Same with higher rates of crime around you. And again, that can potentially be the cause of trauma, but also higher rates of crime, unsafe areas, poorer areas, all kind of clustered together. And what that means is that you're less likely to have safe areas to engage in physical activity and exercise, less access to fresh and healthy food, and higher food insecurity. Both of those lifestyle behaviors, the physical activity and diet side of things, can help prevent and reduce your risk of a mental illness in the future, for example, like a depressive episode. So these factors all can cluster together when you're living in poorer areas. And as we've now discussed, then you might be able to ascertain there's a bit of a cycle here called the poverty trap, where a mental illness in a developing country with low mental health literacy, high rates of stigma, less access to mental health care practitioners like psychologists, can have you having a lower income, can reduce your job prospects, can push you down that economic ladder, which in itself can propagate the mental illness, given it's now difficult to afford mental health care with the lack of access and insurance and welfare. And now you're exposed to some of these, or have a higher rate of being exposed to some of these triggers and stressors, like I mentioned, the crime, interpersonal violence, etc. which then propagates more mental illness, and the cycle goes on and on and on in this poverty trap. So a couple of case studies in places like rural villages in India and in Indonesia show that extreme temperatures or extreme weather events like high temperatures or very high rain seasons in these farmers who are living in these rural areas actually precedes and predisposes subsequent higher rates of depression, higher suicide rates versus seasons where you don't have these extreme weather ranges. And the mechanism here is with this extreme heat and really high rainfall, this can destroy and limit crop yield and cause significant economic and financial stress, thus predisposing people to higher rates of depression, higher suicide rates. So we've established that there are a lot of problems living in poverty, unique risk factors that may predispose you and leave you at higher risk of mental illnesses, and that the relationship does work the other way, where a mental illness can reduce your economic standing. And obviously this varies depending on where you live, and indeed living in higher income countries as well, of course, can lead to stressors and mental health challenges in the sense that mental illness doesn't discriminate economically, but there are unique challenges present for people living in developing countries and poor areas. But we haven't really talked about the solutions. So some of the solutions, and we'll only cover them briefly, but there's a lot of work really being done at digital interventions. So these are like self-help tools on mobile phones, apps, for example, that guide people how to use mental health strategies and tools that you may only get otherwise in the confines of a therapy practice or speaking to a psychologist or psychiatrist. And this is really important given the almost ubiquitous access to smartphones now that we have, that are even happening in places like rural Sri Lanka and India, and people now have greater access to these apps and self-help interventions that we ever did in the past. So a lot of work being done there, and a lot of work being done on culturally adapted apps and interventions. So even in Western countries, we have apps like Calm and Headspace, for example, for more mindfulness-based interventions, but adapting them from Western populations into these developing countries and unique cultures is really important. Again, coming back to what we talked about at the start of this little discussion, where most of the research on mental health interventions is actually done in those weird countries, Western, educated, industrialized, etc. So culturally adapting digital interventions, also training up cultural, spiritual leaders is something that's being done, and training them up to use mental health interventions, psychotherapies that are really accessible, things like behavioral activation, which you can readily train up someone who is not a psychologist or a psychiatrist in to use in their areas. And training particularly cultural and spiritual leaders is important because in these areas, often they are looked to as the leaders, and when people have mental health challenges, it is often the church, the mosque, the temple that they go to, not the clinic or the GP or the doctor, because this is more culturally appropriate or aligned with their beliefs, and also coming back to the lack of access to said health professionals. So training these people up is a potentially really useful way to go about giving people living in developing countries access to mental health interventions that they otherwise wouldn't get. And there's also a case for lifestyle behaviors, particularly something like physical activity, which we've talked a lot about on the podcast and which I'm doing some research in the sense that physical activity is highly accessible and you can engage in physical activity with minimal equipment, walking, running, lifting weights that are the cans of oil in your backyard, the bricks on your wall. These things can and do in fact have a positive effect on your mental health. It doesn't need to be in a gym. It doesn't need to be with a exercise physiologist or a psychologist. So these accessible ways of changing someone's lifestyle can potentially yield a lot of value, given they can be taught and rolled out even in areas without much resources. And there's a bunch of researchers at Uni of New South Wales, led by Dr. Simon Rosenbaum, who've gone out, for example, to Cox's Bazar in Bangladesh, which is where the Kutupalong refugee camp is, one of the, if not the world's largest refugee camp, and have gone out and built things like little spaces for women to engage in physical activity in, women's only spaces, given soccer balls and shoes for people to actually be able to play soccer. And these are really unique, thoughtful, culturally appropriate ways in which you can actually change physical activity levels and potentially use this as an intervention to help mental health outcomes where there's no psychiatrist, where there's no psychologist.